Hello, everyone. Thank you for standing by, and welcome to Infant Toddler Winter Illnesses, our parenting webinar presented by Dr. Nina Shapiro. My name is Nancy Holtzman. I'm the Vice President of Clinical Content and E-Learning here at IsisParenting, a pediatric nurse and board-certified lactation consultant, and I will be your moderator today. During the presentation, all participants will be in a listen-only mode. However, you may submit questions at any time by typing through the chat feature located to the left of your screen, or direct them to us on Twitter using our handle ISIS_parenting. We'll also take questions at the end of the presentation. Today's webinar is being recorded, and all of you will receive a link to the recording later today. So if you missed something or need to step away for any reason, that's okay. IsisParenting is proud to host today's webinar. ISIS is the nation's most trusted prenatal and early parenting destination. We provide innovative programs and a highly edited selection of products for expecting and new families in our 4 Boston area centers and online at isisparenting.com. As I mentioned, my name is Nancy Holtzman, and I will be your moderator today. It's my pleasure to introduce to you our presenter for today's event, Dr. Nina Shapiro. Dr. Shapiro is the Director of Pediatric Otolaryngology, Ear, Nose, and Throat at the Mattel Children's Hospital at UCLA and an Associate Professor of Head and Neck Surgery at the David Geffen School of Medicine at UCLA. She has treated thousands and thousands of children with breathing problems, ear problems, and neck tumors. A graduate of Harvard Medical School, she completed her residency and training at the Harvard program and received subspecialty training in pediatrics, ear, nose, and throat at the Great Ormond Street Hospital for Children in London and at Children's Hospital San Diego. She is the editor of a pediatric textbook and the author of the popular parenting book, Take a Deep Breath, Clear the Air for the Health of Your Child, said by Dr. Nancy Snyderman to be a must-have for every parent and grandparent. Also significantly, she is the mother of 2 young children ages 5 and 9 who have certainly had their fair share of colds and respiratory infections. It is my pleasure to introduce Dr. Shapiro.
Thank you, Nancy, and thank you so much for having me this morning. It's been a lot of fun working on this, and it's a little bit of a trip down memory lane. As you said, my kids were once young, and I have seen a lot of these problems in my patients as well as in my own kids. So I hope that everyone will enjoy this and maybe get a little bit of sort of peace knowing that a lot of what your kids are going through is a part of normal childhood. So to start out, most of the things that we see in children are not really the news-breaking flus that we read about. It's really colds. Most respiratory illnesses are simply cold viruses. And kids get up to 5 to 10 colds per year, and each of these colds can last 4 to 7 days. So if you do the math, if you have 1 child, you're going to have 20 to 70 days each year of a cold. Again, if we move on 2 kids, you're talking 40 to 140 days per year of a cold. 3 kids, you're getting to more than half the year, guaranteed that someone in the house will have a cold. And this is quite frustrating, but unfortunately this is a reality of what we see in our lives. And I'm not even talking about the adults. These are just the healthy kids in your house. And unfortunately, we as parents, adult caregivers, we usually get it worse than the kids. So as bad as they have it, you can have a child with 3 days of a cold, but then you'll be sick for 2 weeks. And unfortunately, their immune systems are better than ours. So we often get sick a lot longer than they do. So how do you know if your child just has a cold? The symptoms, really back to basics. Stuffy nose, runny nose, they can have a cough, they can have a little bit of a fever, they may have a little decreased energy and appetite. They're just sick, they're just under the weather. These kids are not the kids that you want to send to school, but they're not so ill that you're really worried. Colds, by the way, are caused, just a reminder, colds are caused by viruses. So you do not need an antibiotic every time your child has a runny, stuffy nose, cough, fever. Most of them are viruses and they go away on their own. The other thing is most of the over-the-counter cold medicines, first of all, they don't work and they don't help. And second of all, for young kids, and by that I mean kids under 4 to 6, they're not recommended. There's some warnings on the labels, as you've seen, that these medicines, the cough medicines, the cold medicines, shouldn't be given to young children. So not only should they not be given, they usually don't work. They don't really make their cold go away any faster, and a lot of them don't even help with their symptoms. So we really need to just go back to basics when we're thinking about a cold. Basic stuff that we all did when we were kids and we were sick. Rest, fluids. Chicken soup can actually help, or any sort of soup. If you're a vegetarian, you can have vegetarian soup. It's really just the liquid in it, the steam from the warmth of the soup, the electrolytes and a little bit of salt will rehydrate your child. So just basic chicken soup still helps. Nasal saline, if you can spray your child's nose with saline, that just keeps their noses clean. And then this humidifier, this is the crane humidifier that you can see, that pretty pink picture that you see. These are great cool mist humidifiers, and cool mist is really better. You need the cool humidification when you're sick, and it's also a lot cleaner than a warm mist humidifier. The warm ones tend to like to grow a lot of mold and bacteria, so cool mist are best, and these are actually quite convenient. You have to have your child sleeping upright because usually all that mucus that drips back in the back of their throat will be pretty uncomfortable during a cold. So if you can sleep them propped up on an extra pillow, that would be great. Older children obviously can have pillows, not the babies. A nasal decongestant, and for this, even though it's over the counter, something called Afrin or oxymetazoline is safe in children, but you really need to ask your doctor. There are very small potential risks of this, so you want to make sure that it's safe for your particular child. But Afrin is a topical nasal decongestant. It'll open up the nasal cavities so your child will be a little bit more comfortable. Again, it's not going to cure their cold. It's not going to make it go away any faster, but it will make them more comfortable. It can be used up to 1 to 2 times per day. And this is very expected. You will see your child have a little bit of a goopy nose, and with that nose they're going to swallow a lot of that goop, so their poop may be a little different during a cold, and this is also very normal. Acetaminophen or Tylenol or ibuprofen or Motrin can be given for fever. There's some controversy about this because some people say that kids should have a fever and just let them kind of burn it out. But if they're uncomfortable from a fever, it's certainly reasonable to give Tylenol or Motrin. Motrin can only be given to kids 6 months and up. Honey is the new hot cold medicine, and this really has been shown to work. There have been some recent studies showing that honey given for a cough can actually reduce the frequency of coughing. You can give it even at the end of the day or towards bedtime. Buckwheat honey is supposed to be the best for a cough, but a child has to be over 1 year to be able to take honey. Honey shouldn't be given to infants. So when do you know? So we all have had kids with colds, or most of us have had kids with colds. But how do you know when it's more than a cold? And also, what else could it be? So when you're getting past the 7-day mark and these fevers are really becoming high fevers, and we're not talking about 100, 101, we're talking about the 103 fevers, 102, 103, really just a very ill-appearing child. The cough is starting to sound really wet to the point where they can't clear it on their own. They're lasting a long time. And then it gets this kind of barky cough or a hacky cough or a dry cough. Just the quality of the cough has progressed. These are the kids that you really want to have a little more concern and say, hey, maybe this is something more than just a cold. So when is it more than a cold? Again, when there's a lot of issue about what color the mucus is. And frankly, even if it is just a plain old cold, the mucus can be sort of a darker color, and that's usually noted more in the morning when a child wakes up. Their nose will be a little bit more sort of thickened from overnight, so the clear running nose can be a little greenish and yellowish. That, again, doesn't necessarily mean it's something too worrisome. But if you're seeing it all day, green, yellow, green or brown, runny nose, if they're coughing up any mucus that looks really dark, if they're starting to complain of a sore throat, headache, if they can't sleep, obviously any breathing problems, if they're not eating or drinking, then we really need to think, hey, this isn't just the run-of-the-mill cold that we're dealing with. So what else could it be? There's so many other things that it could be, but we really just have to march down the respiratory tract to figure it out. So the highest part of the respiratory tract is actually the ear. The ear is part of the respiratory system. So otitis media, or ear infection, can come from a cold. You can have an ear infection without a cold, but certainly it can be part of a cold or progression from a cold. Sinusitis, and we'll talk a little bit about that. That's a very difficult entity to diagnose in children, actually. Strep throat or tonsillitis. Flu, and these are very sick kids. RSV, which is respiratory syncytial virus, another type of cold virus that can progress into the chest or the lungs of kids. Pertussis, or whooping cough. These are very sick kids. We'll talk a little bit about that. Croup, and then bronchitis and pneumonia. So really you just think from top to bottom, from ears down to the lungs, where else could this cold be going to? So we'll start with an ear infection. And again, this picture of this child, she doesn't have an ear infection. She has an earache, but that doesn't necessarily mean that it's an ear infection. Ear pain can be an ear infection, but it's not always necessarily the case. But when you think about ear infections, they are respiratory illnesses. The middle ear, or the part of the ear where the fluid collects, is in direct communication with the back of the nose. So if your child has a runny nose, a stuffy nose, that fluid sitting in the back of their nose can track up to the inside of their ear. So fluid can develop there. But again, fluid in and of itself doesn't necessarily mean that it's infected fluid. Most ear infections, just as most colds are viral, most ear infections are viral, meaning that they don't necessarily need to be treated with antibiotics. They could even be sterile, where you can have fluid behind the eardrum that doesn't even have a virus. But the reality is they hurt. The eardrum itself has a lot of nerves in it, and it's very sensitive. So any swelling of that eardrum can cause a lot of pain. So symptoms of an ear infection, for those of us who've had children with ear infections or seen kids with ear infections, we know that it's absolutely miserable. They're irritable. They can complain of ear pain if they're old enough, or if they're younger children, they can hold their ears. When a lot of parents say, well, my child had a double ear infection, that doesn't mean that it's doubly worse. Most ear infections are also usually in both ears. So a double ear infection doesn't necessarily mean that it's a worse ear infection. It just means that it's usually in both ears, and that's usually the case. They can have a fever, not necessarily. They can have a cough. And the thing about a cough and ear infections is that oftentimes if you have fluid behind your ear, kids or adults, it'll make you cough. And if you have a cough, that kind of propels the liquid into your ear. So it becomes a little bit of a vicious cycle. The cough can lead to an ear infection, and the ear infection can lead to a cough, and then they sort of play off each other in a negative way. Ear infections, as with most issues with children, it's always worse at night, so they'll not be sleeping. When children lie flat, even during the day for a nap, the ears get a lot more pressure, so it's a lot more pain. When you look at a child who has an ear infection, then you will see in this picture this bulging ear with a lot of red blood vessels on it, and what you see, that yellowish color, that's pus behind the ear. That's not fluid, that's pus, and it really looks like an angry looking ear. Red in and of itself doesn't necessarily mean that it's infected. It can just be, if you look at a child's ear that's red, it could be a cold. It could be from crying, teething, from coughing, or not an infected ear. If you're seeing drainage coming out of the ear, like all of a sudden your child's had ear pain, and then you see some, whether it's bloody looking, pus, fluid, if you see any sort of sticky stuff coming out of the ear during or after an ear infection, most likely that means that the child had this ear infection and the eardrum ruptured. So that big swelling, it's almost like a blister that pops, and the fluid that was sitting behind the eardrum comes pouring out. Now it's a horrible looking thing, but frankly it's not dangerous. They'll probably feel a lot better. You should bring them in to see the doctor because the doctor does need to check it. But the good news is, again, two things. One is that they'll be feeling better because the eardrum pain will go away. And the other thing is that most eardrums that rupture from an ear infection will heal quite quickly. It's just a little broken skin, and usually within a day or two that little hole that's created will close up, just like a blister that sort of seals up after a rupture. So if you do see a child with ear drainage during or after an ear infection, that's probably what happened. But again, I would recommend that you check it out because these ears aren't always so easy to see. So this is just a diagram of what we see and why they're so connected. So the little eardrum between the ear canal and the middle ear, and it's really like a little piece of skin. And then going towards the center in the middle ear is that little space where the ear bones are, and it's a tiny little space. It holds about 1 milliliter of fluid, maybe a little bit more. And then down the little eustachian tube, it's like a little tract. And it's not an actual tube like a structure that you can see. It's sort of this area of muscle, but it goes directly to the back of the nose where the adenoids sit. So if you have a child with a stuffy nose, the fluid can track up that little eustachian tube and then fill the middle ear. So that's how that direct connection is. And the lining inside of the middle ear is the same lining of the back of the nose, respiratory lining. So that's why it's really, we don't really think of an ear infection as a respiratory infection, but it is actually a direct connection to the respiratory system. So what can we do for these horrible ear infections? They're very, very common. If it's a child over 6 months old, you can treat an ear infection for the first 24 to 48 hours with acetaminophen or Tylenol or ibuprofen or Motrin. If the child is no better 24 to 48 hours later, then you can consider having them treated with antibiotics. And obviously you'd have to see your doctor to assess whether it's actually an ear infection to do antibiotics. So, you know, as far as which pain medicine to give, it really depends on your child. Some people think that Tylenol works better for fevers, but Motrin works better for pain. So again, you can't give Motrin in children under 6 months. It's not approved for children under 6 months. But after that, one thing that sometimes we recommend is that if you have an absolutely miserable child and they have a fever that you're really trying to keep down because they're so uncomfortable, you can alternate. So you can give Tylenol, and then 3 hours later, as opposed to waiting that 4 to 6 hours, you can give Motrin, and then 3 hours after that you can give Tylenol. Motrin is much better for swelling. So if it's the inflammatory pain, the swelling pain from the ear infection, Motrin will probably be a better choice. But if they're having a fever, sometimes Tylenol works. But again, if you're just having a miserable child, you'll have to go back and forth. So Motrin and Advil are both ibuprofen, and then Tylenol is what you see for acetaminophen. In some of the drugstores, you won't see it called Tylenol or you won't see it called Motrin. So obviously check your labels. These, you know, there's a lot of issues these days is labeling, and the colors are the same. All the medicines are becoming pink now or clear now. So always check, and if you have any questions, ask your doctor or the pharmacist as far as what you're giving your child. When you have a sick child at home, which many of us know, they really are, you know, you're at your wit's end, so you want to make sure that you know what you're giving. Under 6 months old, even if they're, you know, within the first 24 hours, you do want to start antibiotics. These are the kids that we can't sort of give that leeway of waiting a day or two to see if they get better. And for them, you can give acetaminophen or Tylenol. You cannot give Motrin for the young children. Feverol is another brand that you may see for Tylenol suppositories, and this is for a child who can't keep anything down. They're really, you know, if they're vomiting or if they don't want to take medicine, then, you know, Tylenol suppositories are certainly another good option. So a little bit about the demographics of ear infections. It is the most common reason for a child to go to the doctor, period, is an earache. It is a $3 billion per year direct cost in this country alone. For ear, we're just talking about ear infections. I'm not talking about health care, just ear infections in children. And this doesn't even count for all the indirect costs that we are sort of challenged with, work missed, transportation to the doctor, school missed, parking, everything. So it's a huge, huge health problem. And the reality is a lot of these visits and a lot of these treatments are unnecessary because antibiotics aren't usually needed for ear infections. And one of the problems that we've seen is that because kids have gotten so many antibiotics over the years, the basic antibiotics, the regular low-dose antibiotics don't work for ear infections, and we're on higher and higher doses and strengths of antibiotics because of what we call antibiotic resistance. So moving on to sinusitis, this is just an example of just to show you how small the sinuses are in young children. So in the 1 to 5-year-olds, the sinuses are really like tiny little dots in the nose, around the side of the nose, between the eyes. And they are so small that a little bit of fluid from a cold will look like a quote-unquote sinus infection. In the 12 to 16-year-olds, the older kids' sinuses are more adult size, so they certainly can cause more of a problem. But in the young kids, sinusitis is a very difficult entity to diagnose. So how do you know if a child has sinusitis? Prolonged cold symptoms. And again, we're getting into this greater than 7 days of a cold that really progresses. It seems to be getting worse and not better. The cough really sounds like a deep cough. An older child will complain of a headache, and usually that headache, if it's related to the sinuses, will be in the front part of their head, sort of facial pain. So they'll complain of cheek pain, eye pain, pain around their forehead, not necessarily the headache in the back of their head. Headaches are very challenging to understand in children, but if it's facial pain in the setting of a prolonged cold, you may think about a sinus infection, usually a low-grade fever. And then the other issues that go along with the cold are runny or a blocked nose, fatigue, again the facial discomfort. They may have foul breath because all of that infected mucus that's dripping from the back of their throat into their breath, and then also, as with most illnesses, they won't sleep well. Sinusitis is very difficult to diagnose in kids. If you get an X-ray or even a CAT scan or a CT scan in a child with a cold, it will be read out by the radiologist as sinusitis because sinuses in kids are always filled. The other issue is even if you have a CAT scan in a child who doesn't have a cold or a sinus infection, it will look like sinusitis. So again, sinus infections are very difficult to diagnose even if you're going towards the X-rays and the CAT scans. We have to put together the history of the prolonged illness with the X-ray as well as with the exam. So a very ill-looking child, thickened mucus, and a wet cough. And if it is truly a sinusitis and a sinus infection, these are kids who may need a course of antibiotics to get them better. So moving down a little bit, strep throat or tonsillitis. This is a lovely picture of infected tonsils. You can see the tonsils are on the sides there with those little red, angry areas and the white spots around the tonsils. And this is very painful. This isn't just talking about, a little bit of a sore throat. These are kids who feel like they have a hot poker back there. It is miserable. And with strep, they can also get belly pain. So these are the kids who have very sore throats and a very, very sort of uncomfortable stomach. They may have a little nausea and vomiting as well. They can have swollen glands in the neck, and the glands are actually lymph nodes reacting to the swollen tonsils. And again, they're red, swollen, they're angry looking, white spots, and usually kids with strep will also have a fever. These tonsils are actually much bigger, but this is not a child with tonsillitis. This is a child who just has a very big exam showing that their tonsils fill the back of their throat. So, another question I often get is, so how many episodes of tonsillitis are too many? And if you don't have tonsils, you won't get tonsillitis anymore. So does my child need their tonsils out if they've had tonsillitis? And the guidelines have actually increased over the last few years from our academy, the American Academy of Otolaryngology, and that is that a child who would be a good candidate for getting their tonsils out, they would have to have had 7 episodes of documented tonsillitis per year for 1 year, 5 episodes per year for 2 years, or greater than 3 episodes per year for greater than 3 years. So these are the kids who have the recurrent severe episodes of tonsillitis. The other group of kids, which is actually a much larger group that we see, are the kids who have very loud snoring, sleep disordered breathing, obstructive sleep apnea, daytime fatigue, and this picture here shows a child with tonsils filling the back of their throat. This child had never had an episode of tonsillitis but had significant breathing problems, and that would be an indication to warrant tonsillectomy. So what about the flu? We are in flu season, and as many of us know, it was an early season this year. It peaked much earlier than we expected, which was bad in some ways because it came as a bit of a surprise, but good in some ways because it seems to be tapering out. It was a huge epidemic in Boston, and it sort of migrated west. But in general, the flu season is November to March. The flu shot this year is 60% effective against most strains of the flu, and this is actually good. It doesn't sound that good, but that's actually considered a pretty good flu shot, and I hope all of you have gotten it. If you haven't, it's never too late. This year's strain is H2N3. And again, the flu shot was effective against 60% of the flu viruses that we saw. Flu shots should be given to children ages 6 months and up, and for the first year that they get a flu shot, they have to get it twice. So they go in once and they get their first flu shot, and then 1 month later they get their second flu shot, and that is considered to be fully immunized when they've gotten those 2 rounds of flu shots. Once they've done it once, they don't need to get flu shots twice again. That's just for the first year. Flu mist, which a lot of the kids who don't like needles can take, is a nasal spray, and it's a flu vaccine. Works the same way, and that's given to kids age 2 years and up to adults age 49 years. It's also highly recommended during pregnancy, especially if you're pregnant during the flu season. It's a very good idea to get the flu shot during pregnancy, and it's considered to be safe. And it takes about 10 to 14 days to become effective, which is actually a long period of time. And if you wait to get your flu shot during the flu season and then you get the flu 5 or 6 days later, it is the flu. It is not from the flu shot. You cannot get the flu from the flu shot. You can sometimes get a little bit of soreness at the site, maybe a little bit of a cold, but you will not get the flu from the flu shot. But it does take about 2 weeks to become effective after you've gotten the shot. So the flu is a virus just like the cold virus. It's obviously a much more virulent or strong virus, so antibiotics will not help if you have the flu. You can get what's called a superinfection, which means that you have the flu, and then on top of that you get a bacterial infection. But again, most of the people who get the flu, even if they're quite sick, it's just the virus. There are 2 antivirals. The trade names are Tamiflu and Relenza, and these may cut the symptom duration. They will not cure the flu, but they may cut a day or 2 out of symptoms, which if you've had the flu, if you know someone who had the flu, that day or 2 can be very significant. It's quite miserable. So those are the options, and those are safe in kids 1 year and up. The spread is by droplet exposure, so it's very, very contagious once you've gotten the virus. And as opposed to a cold or a sinus infection or even a sore throat, these symptoms hit hard and fast. They hit you like a brick wall. This is to the point you can't even call somebody to tell them that you're not coming to work that day, you're so sick. Extreme fatigue, extreme weakness, high fevers, cough, nausea, vomiting, nasal congestion. And this is miserable in adults and kids, but in babies obviously it's much more significant because these kids really can go down quite quickly. So if you do have an infant with the flu, you need to be very aggressive in treating them, meaning bringing them to the doctor, making sure they're hydrated, treating the fever, making sure they're getting enough in, and not progressing to get too sick. And then moving down a little bit, RSV. This is also, we're sort of getting into RSV season. It's respiratory syncytial virus. Again, it's another virus very similar to the cold virus. Most kids who have RSV, it's pretty mild, and you don't even necessarily know that your child has RSV because usually it presents itself very similarly to how a cold would present itself. The season is late winter and early spring, so we're just sort of getting into RSV season. We start to see a lot of it February, March. It's most common in infants and toddlers, and it may progress to a bronchitis or a pneumonia. In infants, it can be just a cold, but it can progress into the lower respiratory tract to cause some breathing problems. It also may progress to something called bronchiolitis. And so if you think of the air passages, you have your windpipe where you breathe in, and then it splits off into the bronchi, which are sort of like these straw-like passages. And then the bronchioli are the smaller, tiny, tiny little tubes between the bronchi and the lungs. And if these get clogged up in an infant, it can cause significant breathing problems, very similar to a pneumonia. So how do we prevent RSV? Well, there is a vaccine for RSV, but unfortunately it's not, everybody does not get the RSV vaccine. It's very, very focused vaccine to more sort of susceptible infants. So there's some guidelines that the American Academy of Pediatrics has created for this vaccine. The trade name is Sinusitis, and that's for kids 2 and under who have chronic heart or lung disease, very premature children. So as you can see in this picture, a child born at 28 weeks or earlier who's under a year during the RSV season, which is now, again, about February, March, or a child who's born between 29 and 32 weeks who's under 6 months during the RSV season, a child born 32 to 35 weeks who's yet less than 3 months during the RSV season, or any child who's born before 35 weeks with any sort of neurologic problems. So the Sinusitis vaccine is also given in stages. It's not one vaccine. There are a few boosters that a child can get. But because RSV in these very susceptible children can be quite significant, these kids really do need to be protected. So how do you diagnose RSV? So these are kids that go to the doctor, with a cough and a cold, that they may be a little sicker than the usual cold. And obviously in the younger, more susceptible infants, they could be quite sick. It's diagnosed with a rapid nasal swab, which you can get the results in the office in about 20 to 60 minutes. And again, these are the kids where it progresses from a cold to a bronchiolitis or a pneumonia. And again, the bronchiolitis is inflammation of the lining of the very small airways. And these airways are pretty much the size of a cocktail straw, so very narrow in the child's airway between the breathing passages and what's leading to the lungs. And then it can progress to pneumonia, which is a true lung infection. It's still a bit of a big problem. We see about 100,000 hospitalizations each year for RSV and up to 4,500 deaths per year if RSV progresses to a pneumonia that can't be treated. So what is the treatment for RSV? Most kids who have RSV are treated at home, similarly to how you would treat a cold. Very basic measures, a humidifier, cool mist humidifier is great, nasal saline, pain control or fever control if they're uncomfortable from a fever, keeping them hydrated, lots of fluids. If it's an ill child, these are the kids who end up in the hospital. Some of them just need a little oxygen supplementation, very close monitoring, breathing treatments, and again, some of these can progress to require an intubation where they actually need to have a breathing tube placed and placed on a ventilator. Thankfully, this is quite rare, but if it's a young child who's very sick from RSV, these are the kids who need a little breathing support temporarily. Pertussis. This was a disease that I read about in medical school and I never saw, and I went to medical school quite a long time ago. But unfortunately, this is something that's back. And out here in California, there was an outbreak in 2010 with greater than 9,000 cases of pertussis. And again, this was a disease of the history books, and now it's back. There were 10 infant deaths in California alone from pertussis. Now, babies who receive their pertussis vaccine, and this is part of the DTaP vaccine, even if they're receiving it on schedule, which is 2 months, 4 months, and 6 months, they're not actually immune to pertussis until they are 8 months old. So if you have a young infant under 8 months, even if they receive their vaccines on schedule and they're exposed to somebody who has pertussis, they can get it. So you really want to be careful about these babies' exposure because you don't know who's not been properly immunized. If you have a school child, your immunization rate of your particular school, whether it's a public school, a private school, a parochial school, these immunization rates are public and available. You just have to find your state's website for immunizations, and you can find out how many kids in your school are actually immunized. There's a great website. It's where you can see right here, soundsofpertussis.com, and you can hear what pertussis sounds like on that website, and it is frightening. And this is a real problem. So we really need to get these kids protected because unfortunately this disease is now back in society. We used to call it the 100-day cough because it can really last 100 days. And we're not just talking about that irritative cough that you have. These are really horrible coughs that can last to the point of you're not being able to breathe. Some people vomit while they're coughing. And these are adults as well, not just the kids. So it's now also recommended that pregnant women receive an extra booster during their third trimester, especially if they're due for their Tdap, which is sort of the booster version of the DTaP vaccine, which includes tetanus, diphtheria, and pertussis. And the nice thing about that is that if you receive the vaccine towards the end of your pregnancy, your baby will have a little more protection than an unimmunized baby in the first few months of their life if they're exposed to somebody with pertussis. So again, the DTaP vaccine is given at 2 months, 4 months, 6 months, and then again a booster at 4 to 6 years. And then the Tdap is given to 10-year-olds now, and then every 5 to 10 years plus during your pregnancies. So croup, we're moving a little bit more down the respiratory tract. So croup is again caused by a virus. So you're getting the theme here that most respiratory illnesses are viral and don't need antibiotics. So really we need to sort of steer away from that need, feeling that antibiotics are going to make us better, because it's actually not usually the case. If you get better when you happen to be on antibiotics, it's probably just a coincidence that you'd be getting better anyway. But croup is caused by another virus similar to the cold virus. It's called parainfluenza virus. It is not the flu. It has that influenza word in it, but it's not the flu virus. It's most common in 3 to 18-month-olds, although certainly you can have a child who has croup later on in childhood, and there are kids that get it even in elementary school. Thankfully, it's usually less severe than the infants. And what it is it's an acute swelling of the windpipe or trachea, so the main breathing area, right below the vocal cords. It swells up suddenly, and you have this horrible bark-like cough in the middle of the night. And as with most things, it's usually in the middle of the night, and it can cause some breathing trouble, but it's a very distinctive cough. It sounds like there's a seal in the next room. And because there's such narrowing at the very large air pipe, it can cause a lot of breathing trouble. So if you hear this sound, what do you do? I wrote a book called Take a Deep Breath, but for this you need to take 2 deep breaths because you are in for a long night, especially if it's the first time your child has had croup. First thing to do after you've taken a few breaths, and don't panic, is go outside with your baby. And bundle your baby first because, again, it usually happens in the winter or the spring, so it's going to be a little bit cold. But there's always a little more humidity outside. So go outside. We always talk about a steam shower, and that's great, but it takes a little while to get that steam going. But you can just run outside with your baby. And just having your baby upright will help their breathing a little bit because they'll have been lying down. They'll have a lot of mucus, a lot of secretion. So just keep the baby upright. Bring him or her outside. Steam shower can help, but also we're always talking about these cool mist humidifiers. So a real quick cool mist is your freezer. There's nothing colder than freezer air, and it is humidified. So I know this sounds a little bit funny, but you can open your freezer door and sort of stand there with your child. They're not going to like it, but it'll probably open up their airway a little bit. If all of these measures don't help and your child really seems to be in distress, that's the time to go to the ER or even call 911. And I always recommend, if anything happens with any child and you're in a panic, if you have other kids at home, don't forget about the other kids. Don't leave them at home. If you're going to go to the emergency room, bring them in. Unfortunately, you have to bring all the kids if all the parents are going to go. If it's really seeming that bad and you're worried about not getting to the emergency room, if your child is in that much distress, then obviously call 911. So let's say you get to the ER. What are they going to do? First of all, if you get to the emergency room and your child is better by the time you get there, which is almost always the case, do not turn around. You've gotten to the ER for a reason. You need to be there. Even if you feel a little bit silly, hey, my kid is fine now. I don't need to be here. Have them checked out if nothing else, because obviously they were sick enough for you to bring them to the emergency room in the middle of the night. You want to find out what's going on. So what are they going to do in the emergency room? They're going to give your child some breathing treatments and nebulizers, and it's always a good idea to ask them what they're giving, not necessarily confrontationally, but just to know what your baby is going to be given. Most kids who've had croup will get it again, so you want to know what works for your baby. They'll probably give them a little bit of oxygen, and one of the best medicines for acute episodes of croup is steroids, oral steroids or even a shot of steroids, and usually just one dose will get that baby better within 10 to 20 minutes. They may want to monitor the baby, monitor their oxygen, heart rate, make sure they're comfortable, make sure they're tolerating it well. And then they may send you home with a prescription for steroids. And these are very safe. Certainly there are always risks to medications, but the steroid medications are very safe, and these are usually very short term, for a few days. And it'll be enough to make your baby better. And again, no, you don't need antibiotics for croup. So if your baby's had croup once, unfortunately he will likely get it again, but now you know what you're in for, so be prepared. Not every episode of croup is the same, but at least you'll have some sense of what to expect in the future. You can talk to your pediatrician about possibly having a prescription for steroids filled, not necessarily to take on your own, but if you're traveling or if it's in the middle of the night again and you know that one dose of steroids has worked in the past, if your pediatrician and you are comfortable, you may want to just have that at home and take that one dose to see if that will save you a trip to the emergency room. And then also for travel, you want to have that, certainly if you're going to be on any airplane, you don't want to be stuck with a croupy baby. And really I like to think about the worst case scenario. There's that book series called Worst Case Scenario. What's the worst possible thing? Well, the worst possible thing, which I can definitely say was an experience, is we're in the desert and it's Easter Sunday and your child has croup. You can't go outside because it's so dry outside, and your child is barking like a seal. So really think about the worst possible scenario, and it would be nice to have some medications with you. If your child has responded to nebulizers in the past, you may also obviously want to travel with those if you tend to have a croupy baby. So now moving down a little bit more, bronchitis. So now we're below the windpipe into the bronchi, which sort of splits off from the windpipe to the small air passages. So bronchitis can be viral or bacterial, and this is difficult to sort of differentiate. And again, the bacterial bronchitis tends to be a much sicker child, higher fevers, more breathing problems, and these are the kids who may need antibiotics. And so it's an extension of the respiratory infection to the small airways between the windpipe and the lungs, and that's that deep, wet cough, uncomfortable child, they're fatigued. They may or may not have trouble breathing. The older child usually just has a nasty cough, but an infant can really have trouble breathing from bronchitis. What is the treatment? Again, if it is concerned for a bacterial infection, and this is often difficult, in an adult we can usually get what's called a sputum sample, where an adult will spit into a little cup and we can check a culture. This is obviously very difficult to obtain in a young child. But if it's a very sick child, then the doctor may consider antibiotics. A humidifier, again, a cool mist humidifier. Keep it clean as best you can, because you don't want to be sort of spreading more germs or mold or bacteria into the air. But that will help with the inflamed airway. A nebulizer, and again we'll talk a little bit about what's in these nebulizers and how that can help for bronchitis. And then just basic, back to basic rests for these kids. Pneumonia, and these, if you have a young child, an infant, pneumonia can be quite worrisome. It can also be bacterial or viral, and again, the sicker children, it tends to be more likely bacterial, so they may need antibiotics if it's progressed and it's a child who's in a lot of distress. The diagnosis of pneumonia is by physical exam, so the doctor will simply listen to the child's chest, and if they don't hear airflow, that means that the lungs are not moving any air, and there's some blockage there. And then a chest x-ray, as opposed to sinus x-rays for a sinus infection, chest x-rays are actually a very good way to diagnose pneumonia. If it's an infant who's very sick, they may need to be in the hospital. Cool mist humidifier again, they'd use these in the hospitals. We recommend using them at home. And even using them at home all winter long is a good idea if you have a child who's susceptible to respiratory illnesses. I have plenty of patients who use cool mist humidifiers all winter long, really just to prevent a lot of these illnesses. And then if it's a sicker child, they may need to have oxygen and nebulizer therapy. So nebulizers, these are very common. And I think as a parent or a caregiver, it's great to understand what these are and why you're giving them and why they work or why they don't work. So these can be given for acute breathing problems, so bronchitis, pneumonia, or even croup, or for chronic breathing problems. So a child who, let's say they have a cold and they're better from their cold, but then for 3 weeks, 6 weeks later, they're coughing every night. This is a child who may need a nebulizer. They may or may not wheeze with these coughs. They may just be coughing. Or a child who just coughs and wheezes all winter when they're not sick. This is a child who may need to be on nebulizers. And then the older kids who cough and wheeze with exercise or cold temperature, there's something called exercise-induced bronchospasm, or EIB. Apollo Ono, many of you know the Olympic skater, recently came out talking about how he has EIB and how he's treated with nebulizers to allow for him to breathe and skate so well. And then there are the kids who cough and wheeze all the time, whether or not it's cold or hot or whether they're sick. These are kids who may need to be on nebulizers. None of the above, especially in the young kids, means that this is an asthmatic or that they will necessarily go on to have asthma. There are thousands, hundreds of thousands of kids who are on nebulizers as infants, and they eventually grow out of it. What they actually have is something called reactive airway disease, not necessarily asthma. And what that means is that their airways are reacting to something else, usually a cold or a sinus infection or even an ear infection or congestion, and that all of that mucus from the top part of their respiratory system is dripping into their chest, and their chest is reacting by getting clogged up and inflamed, and these nebulizers sort of get them through those reactions. So what's in them? A common nebulizer is something called albuterol, or Xopenex. And these are bronchodilators, and what they do is they open up the blocked or narrow bronchi, or the bronchioles, and it's used during acute breathing problems. It can help with coughing, wheezing, or trouble breathing, and it's usually used, again, it will work during an acute problem. It may cause some jitteriness or increased heart rate. That's one thing to definitely know about albuterol or Xopenex. And you can see the child here, he's actually receiving an inhaler with a spacer. So this child is actually just receiving a one-time treatment. And again, this could be albuterol or a long-term medication for an acute breathing problem. Another common nebulizer medication is something called budesonide or Pulmicort, and this is an inhaled corticosteroid, so it isn't a steroid, and what it does is it reduces the swelling of the small airway on a long-term basis. So this won't work if your child is having an acute or sudden breathing problem. This is something to use long-term. It doesn't work so well if your child is having a sudden breathing problem or wheezing or coughing. It's used as a maintenance medication to prevent breathing issues. So how do you do it? It's very easy to say, to send your child, your infant, home with a nebulizer, a little portable nebulizer machine, and here's the medicine, here's your prescription, go for it 4 times a day. Not so easy when you have a little baby. These babies don't like it. They don't want something on their face. So this is where you really have to work with what works best for your baby. Distraction is usually the best thing. This is where you sort of decide, oh, I don't want my baby to watch TV. This is the time for your baby to watch TV if that's what works. Videos, songs, a smartphone, whatever will work to keep your baby happy, because if you're going to need to do this 4 times a day, you need to survive. So a comfortable setting, whether it's whatever is comfortable for your baby, the high chair, your lap, a bouncy chair. Let the child, before you really go for the first treatment, let them hold it. Let them see that it's not sharp, it doesn't hurt. And then turn on the nebulizer and let them just kind of run it around the room, see that it's also not going to hurt. Let them put their hands through the steam. Let them know that it's painless, that it doesn't smell bad, it doesn't taste bad. And so the first few treatments, don't really worry about getting them treated. Just get them used to the mask and used to the steam, and then gradually get them closer and closer to the vicinity of their face, and then eventually they'll get it. Now you can see that they have these fun masks with little animals on them, and the child can do it themselves, so it's a little less frightening than it used to be. So newborns are really, they are not the same as babies. Newborns are really different creatures. So when it's a newborn, all this issues for colds, really, it's a different story. A newborn with a little bit of a fever, 100.4, if they're under 6 weeks old, this is a child that needs to go to the doctor right away. We take newborn illnesses quite seriously, again, because they have virtually no immunity. Their airways are quite immature, so they really can't fight infections like older infants can. Fever over 101 in a 3-month-old also needs to go to the doctor right away. Again, they're immature immune systems. They have immature breathing passages, so these need to be taken more seriously. There is some immune status passed on from the mom, from their pregnancy. If they're breastfeeding, that's also very protective for a child's immunity. So, but again, these kids need to be seen quite quickly. And then what if they're not sick? Again, we're talking a lot about winter illnesses, but there are plenty of kids who have stuffy noses. So what if you have a child who has a stuffy nose and they're not sick? I mean, it's gross, but it's not dangerous. Again, you know, the toddlers that we send to preschool with a stuffy nose and they're not sick, and you feel like you need to get a note from the doctor to tell the teacher that they're not really sick. What else could it be? It could be allergies. It could be big adenoids. Adenoids are an area of tonsil-like tissue that sits behind the nose, and these can be enlarged in younger kids, younger than we would see kids with big tonsils. And these are the kids who seem always sick, but they're not. Another thing to consider, and this is it's always a great story in retrospect, it's not always so fun at the time, is sticking something up there. And this is a great little sort of fact, is that girls, even though this boy is picking his nose, girls are 5 times more likely to stick something up their nose specifically, not ears or throat, but nose, than boys. So if you have a girl who has a stuffy nose on one side for a long time and then it starts to smell, the first thing you want to think about is what's up there. It'd be amazing what you find. It could be tissues, it could be cereal, it could be beans that start to sprout, it could be corn kernels. Girls love to stick stuff up their nose. It usually smells bad after a while because the mucus just collects and it doesn't drain. So prevention, we've obviously talked a lot about all these illnesses that kids have, but the best prevention that we have is really soap and water, hand washing. The wipes that we use, if you're on the go, obviously those are okay, but really soap and water is best. You have the friction of washing the hands. The soap is a little sort of better quality than the wipes that we use. Wipes are great for travel, but when you're home or at a place that has a sink, soap and water is really best. And teach it as early as your child can stand up. One thing they need to learn how long to wash their hands is a song, ABC song, Twinkle Twinkle, Happy Birthday. Those are actually all the same song. So they can pick the song, and that's how long they need to wash their hands. The other way to prevent is cover your cough. When I was in school, we would cover our cough with our hands, and obviously then you'd touch your friend. So the best way to cover your cough is in the crook of your arm. Cover your cough or your sneeze. So that's also a great way to prevent these illnesses from spreading. And then toddlers, if there's a newborn in the house and a toddler's out at preschool, it's a good idea for them to change their clothes, at least their shirt, when they get home from preschool, because there is all sorts of stuff on their shirts that can spread to a newborn. The other thing is if you have a sick child or even a sick adult in the house, those hand towels that you have in the bathrooms, those shouldn't be shared because those also will contain a lot of the viruses. So again, other things to prevent, good old nasal hygiene, especially if there's nothing stuck up there, if your child doesn't have a foreign object up their nose. Good old nasal hygiene, spraying their nose with saline as many times a day as they will tolerate. And again, just to teach your child, if they put something up their nose, just like croup comes back, foreign objects come back. Kids, these girls are what we call frequent flyers, and if they've done it once, they'll do it again. So you have to teach them early that their noses are not their pockets. And if they want to find a little bead on the ground, they can put it in their pocket and not up their nose. Nasal saline is great to use as a spray or an irrigation, and every family member should have his or her own labeled bottle of saline, labeled because you don't want to share these. And then especially in the newborns, you go home from the hospital with one of those nasal suctions. Really the best thing to do is irrigation with saline. Even in a newborn, it's much better than suctioning. It's better if your baby has this done when they're upright, and give a couple good strong squirts to each nostril. Most of it will drip back out, but it's actually acting as a great irrigator, sort of like a direct humidifier. To have the humidifier and saline is really a great combination. So again, prevention, protect yourself and those around you, wash your hands, and get immunized. And I want to thank you, and I'm happy to answer any questions.
Oh, thank you so much, Dr. Shapiro. Wonderful information. We do have quite a few questions that came in. You answered quite a few of them during the presentation, but I have a few that I thought would be good. The first is, can you talk briefly about how secondhand and third-hand tobacco smoke can affect the respiratory health of children?
That's a great question, and fortunately in a lot of cities we're seeing a significant reduction in smoking around children. But secondhand, third-hand smoke exposure in babies can have a definite negative impact on their respiratory system. It's been found to increase the likelihood of asthma. If you have a child who is prone to asthma and they're exposed to secondhand smoke, it will increase their risk of having long-term asthma. Even if you live in an apartment building where someone is smoking in another apartment, it can go through the vents and can cause problems with the respiratory system, increased episodes of bronchitis, increased episodes of even ear infections from secondhand and third-hand smoke exposure. So even if you're smoking out of the house, all of the toxins that are left on your clothes can have a definite negative impact on a child's breathing.
And next to sleep position, it's the second highest risk factor for sudden infant death syndrome as well.
Right,
so certainly,
right.
And again, same with the third-hand smoke. You know, a smoker who goes outside and has their cigarettes but comes in and carries the chemical on the clothing still is exposure.
Yeah.
Next question, a lot of related questions about, will my child be more prone to asthma? Will my child who's had multiple croup or reactive airway illnesses as an infant or toddler, which child is most at risk for asthma? How can we either help parents relax about the fact that their child might outgrow this, or know that their child may actually be at a greater risk?
Well, there is, if your child has reactive airway disease, they are at slightly increased risk for developing asthma later on. But again, it doesn't necessarily mean that they will become an asthmatic. Kids who have a strong family history of asthma, kids who have, there are other associated illnesses or entities that we see in asthmatics, history of eczema, history of strong environmental allergies. These kids have a higher risk of developing asthma later on because those sort of go together. A child who's had croup, a child who's had need for nebulizers, occasionally with illnesses, that's not necessarily an asthmatic child. It's more the child who has chronic breathing problems. They're slightly more susceptible to becoming asthmatic. And really until they're about 5 or 6 years old, you can't necessarily call a child asthmatic if they need breathing treatments.
Okay. And then even some children that may have even childhood asthma do tend sometimes outgrow it as adults. I know.
Absolutely. Or had a
lot of asthma, no longer.
Yeah, yeah.
Okay, questions about ear tubes and recurring ear infections. So I'll combine several questions together. Is there a way to prevent the frequent colds and congestion from progressing into an ear infection, like using decongestants? And how many ear infections is too many, and who gets ear tubes?
Okay, so as far as prevention goes, the best way to prevent ear infections in a young child, and by that I mean a child under 2, is the way to prevent colds. So hand washing, nasal saline, humidifiers, breastfeeding actually can reduce the frequency of ear infections. So those can minimize the frequency of ear infections and the susceptibility. As far as how many is too many, it really depends. We say roughly, if a child has had more than 6 real ear infections, by that I mean documented by the doctor that your child has an ear infection on 6 separate episodes over a 6 to 12 month period, that may be a child who would benefit from ear tubes. The other kids we see are these kids who have ear infections that just can't clear. So they're treated with antibiotics after a prolonged ear infection, and then they go back for their follow-up and they're still not better. And then 2 months later they still have fluid in their ears and they're starting to have hearing problems and speech problems. Those are also the kids who may benefit from ear tubes. So it's not really a cut and dry number. It also depends on how severe they are. I had mentioned eardrum perforations. If this is a child who every time they get an ear infection, their eardrum ruptures, and then over time you start to develop some weak spots in the eardrum, that may also be a child who would benefit from ear tubes.
Thank you.
Sure.
Well, we've come to the end of our presentation time with you, Dr. Shapiro, and I want to thank you for your time and the excellent information you shared. I'm going to send a follow-up email later today that has your information to your website, to your book, Take a Deep Breath, and a link to the recording to this webinar as well. But again, thank you so much for sharing your information with the audience, and thank you for everyone attending, and we hope to see you soon at another IsisParenting e-learning online event. Have a wonderful day.
It was a lot of fun. Thanks again for having me.
Thank you.